So the first specimen is from a 73-year-old female who is a past smoker. This is her pleura effusion specimen. So this is one of the case that I would want every resident who graduate will be able to recognize it. Yeah, because sometimes the screener can miss it. So as a sign-out doctor, you really need to catch it. Because it is so tiny, it is kind of difficult to catch it because it looks like inflammatory cell under a low power view. But when you get to higher power view, this is the size of the normal lymphocytes. This is mesothelial cells. So you see these relatively small cell because it has the same size of the nucleus of the mesothelial cell, but with a very high NC ratio. The chromatin pattern is granular, is finely granular, and this is the India fire arrangement with nuclear molding. So again, here we see the nuclear fire with molding. Sometimes you will also see, this is the molding pattern. Sometimes you will also see cell-in-cell pattern. So when you see these very dark, very tight, smaller cluster of the cell, you need to think about small cell carcinoma. So I think this is a classic case of small cell carcinoma involved the pleura effusion. The patient already has been confirmed of the diagnosis, so it is not difficult for us because the clinician already put it in the requisition sheet. However, if it is a new patient, you really need to pay attention to these details of the cytomorphology. So again, it looks very not obvious, but you see the molding pattern, and you compare the size and the chromatin pattern of the adjacent normal inflammatory cell. This is small cell carcinoma. Here you also see this Indian fire molding pattern. This is small cell carcinoma. Okay, here you start to see the cell-in-cell pattern and the molding as well. So this is small cell carcinoma involving the pleura effusion. The next specimen is pancreas EUS guided aspiration. So this one is relatively easy because you see the high-grade morphology. The cell arranged in a large cluster with a glandular pattern. There are a large vacuole in the cytoplasm. So this is adenocarcinoma of the pancreas. So the next specimen has a past history of lung cancer. And this is the pleura effusion specimen. Again, this this cancer we are very familiar with. It's easy to detect because it almost always forming a tight cluster with higher grade like a nuclear atypia. So this is positive for adenocarcinoma. And because the patient is under treatment, within these cluster there are some necrosis type, choreresis type pattern because the patient is currently under the treatment. This is positive for adenocarcinoma. The next specimen is from peritoneal washing. The patient received radical surgery for ovarian cancer. The cancer type is clear cell carcinoma. So here in these washing cytology specimen, we see there are some like a core material inside this cluster. It can be a calcified material like Psammoma body, and the cell morphology is high grade with a lot of bubbly cytoplasm and arranging a glandular pattern. So this is adenocarcinoma. We go to a flattened area, we do see quite prominent bubbly cytoplasm. So this is compatible with clear cell adenocarcinoma of the gynecology tract. So the next specimen, we've seen the specimen a couple days before. This is coming from a 31-year-old male patient. This is a large soft tissue mass in the lower limb. So we talk about the differential diagnosis when we see this cytomorphology. The cell is very uniform. It is short spindle. It's not very long, mostly oval to very short spindle, and it is uniformly monotonous. The chromatin pattern is very, very delicate. So this looks like a translocation sarcoma. With this short spindle morphology, the most common sarcoma would be the synovial sarcoma. So we use the residual specimen from the liquid-based cytology to do a cell block. So indeed, we have a lot of tissue here. So these show the similar cytomorphologic pattern that we see, that the cell is very uniform with delicate chromatin pattern. It is mostly oval to short spindle and arranged in a very I would say patternless, because it's going everywhere, a patternless pattern. It is highly cellular. Sometimes for the synovial sarcoma, it can also show a Stackhorn type of vessel pattern. So you do see some dilated syn wall branching vessel. But it does not like the solitary fibrous tumor that had a more collagenous background. It is very, very cellular. So nowadays we have a very specific and sensitive immunohistochemical marker which detect the fusion site, exact fusion site of the protein, which is SS18SSX. So the antibody just catch the fusion site, the peptide around the fusion site, and it can show this diffusely positive nuclear pattern. So with this antibody, the case is confirmed to be a synovial sarcoma. We also have some more traditional, more non-specific marker, such as TLE1, so it can also be diffusely positive in the nucleus. For the synovial sarcoma, it is one of the sarcoma that can have these unusual, very patchy standing for the CK. Even though this is a monophasic synovial sarcoma, not biphasic synovial sarcoma with more epithelial component, in this short spindle cell, you can appreciate they are very strong stand, like a very scattered cells positive for CK. This used to be one of the most helping marker for correctly identify synovial sarcoma. So you see these scatter CK standing pattern. So we will sign out this case as a synovial sarcoma because we have the confirmatory immunohistochemistry. And please just scan the IHC, and this can be saved for the teaching slide and can be used for the case presentation this year for the annual meeting. So the next specimen is coming from a patient with a pancreatic tumor, and this is also from a EUS guided biopsy. So in this specimen, again, we see mostly tumor cells. So sometimes we see a lot of tumor cells. Sometimes we see a lot of contamination from the normal tissue, including the intestine and the normal pancreatal pancreas parenchyma, acinar parenchyma. So here we see a tight cluster, a little bit three-dimensional with polymorphism. The chromatin pattern is vesicular with prominent nucleoli. So this is positive for adenocarcinoma. In the background, we also see some like necrotic debris. So this is necrosis that show in the liquid-based cytology. And the other cells are just like a high-grade adenocarcinoma. So this is positive for adenocarcinoma. Let's move to the pap smear. This is a 47-year-old female. So on low power, it's cellular. It's relatively clean. We don't see a lot of inflammatory cells in the background. So in this low power feature, we know that we are looking for either precursor or organism, microorganism. So here we see a superficial cell with enlarged nucleus. Comparing to the adjacent intermediate cell, it's a little bit hyperchromasia, but not that high. And it still maintains a low NC ratio. So the cell looks like ascus. So then we start to see more these type of cells. So again, a superficial cells with enlarged nucleus, and you start to develop these perinuclear halo pattern with a sharp margin. So this is a coilosity change. So here we also see a coilosity change involving the intermediate cells. So I think for this case, it is okay that we just call these a low CO. So this is a case of low CO. In the other slide, we also see a couple like coilocyte. So this is a low CO case. So the next specimen is coming from a 67-year-old female. So who already in the postmenopausal stage. So on low power, you can see this is totally different from the prior specimen that we see more like inflammatory debris. Most of the cells are intermediate cells in a larger fragment instead of like individual cells. And we also see a lot of necking nucleus in the background. So this is a classic pattern for atrophy smear. For patients already in the elder age with the atrophy like a cervix, it is very common that we can see some enlarged cells. Seems to be quite hyperchromatic. However, if you take a look of the chromatin pattern, it is mostly a degenerative or a smash pattern. And if you check the NC ratio, you didn't see the increased NC ratio, a sharp like membrane that you can tell it is an increased NC ratio. So you find these areas scattered around the entire smear, which is a common change for reactive change for atrophy. So when we see the specimen like these, be aware, do not overdiagnose these as high CO. So in the atrophy background, I think we should be more conservative. And so for these, at most, you can call ascus, but do not rush into the high CO diagnosis, especially the patient is already 67-year-old. And in her requisition sheet, the clinician already put a note that the patient already have already received hysterectomy specimen. So which means there is no cervix in this patient. So the smear is coming from the vagina. So it is there is a much lower risk to develop a precursor lesion by HPV in the vagina comparing to the cervix. So overall, we do see some atypical cells, but these atypical cells had low NC ratio. The chromatin pattern is matched. It is very frequent that we can see naked nucleus, and the smearing pattern, it is throughout the entire smear. And so for these elder patients, we would just call this atrophy. We don't need to call this ascus, especially the patient already received hysterectomy. So the original screener just put the high seal. This is a little bit over. The sign-out doctor downgraded to ascus, but I think we would be pretty safe to just call this atrophy. The patient has prior screen smear last year in our hospital. We also sent out as an atrophy. So I think we just save this elder lady from more examination. So we just call it atrophy. So that is all the case for today.